At ASCO 2018, we've gotten some new information in the squamous lung cancer setting now, along with non-squamous non-small cell lung cancer, that supports giving chemo in combination with immunotherapy for a broad range of patients with any degree of PDL-1 expression. And I think that some people will be inclined to look at this development and say that we don't necessarily need to do PDL-1 testing anymore. I would say that that is not the approach I would take, and I definitely favor still doing PDL-1 testing, largely to clarify whether immunotherapy, specifically pembrolizumab monotherapy, is an attractive option instead of chemo with immunotherapy. The KEYNOTE-042 trial was presented in the plenary session and looked at giving pembrolizumab monotherapy not only to the group with high PDL-1 expression of 50% or greater, which is about 30% of our patients, squamous and non-squamous, which is a standard of care now based on the previously reported KEYNOTE-024 trial, but KEYNOTE-042 broadens that to pembrolizumab monotherapy in patients with PDL-1 as low as 1%. And it is positive for an overall survival benefit compared to doublet chemotherapy, squamous and non-squamous. But I would say that this is not the approach that I would be most inclined to do for the patients with low PDL-1, because the results in the patients with 1 to 49% expression is not clearly better with pembrolizumab monotherapy compared to doublet, and the trial did not include crossover to pembrolizumab after progressing on chemo. So in balance, I would say that PDL-1 testing is still worthwhile to identify which patients are good candidates for pembro monotherapy over increasingly considering chemo and immunotherapy together, and I would use a 50% threshold for PDL-1 expression to make that determination.